excited about this evening's program. As you know, we've been trying to keep it light the past couple of weeks, but we've been trying to get on someone who is an expert to talk to all of us about coronavirus, COVID-19, and we want to have a conversation. And we're just so very honored and blessed to have Dr. Maurice Shoals with us this evening. Hello.
Hey guys, glad to be here with these beautiful sisters.
Yes, we're so happy to have you. So in lieu of running down his entire CV and 5-page all the credentials, we're going to say this. He's a proud graduate of Southern University at Baton Rouge. He's a Jaguar. He is also Harvard educated physician. He has his MD and PhD. He is knowledgeable, and so he's a native of Baton Rouge and a New Orleanian, which you know is important to us as Louisiana natives. So we are humbled and glad to have you.
I'm your homeboy in all ways.
Yes. And we are humbled and glad to have Dr. Maurice Shoals with us tonight. Welcome. How you doing?
I'm doing great. Great to be here.
All right. So I'm going to try to start a watch party on my side, but we want you all to join us tonight. Get in the comments in this conversation. This is an important conversation for us to have. This is when we say a for us, by us type of thing, this is a for us, by us type of conversation. And we really want to get into it tonight. And we're not doing hot topics as we normally would, because what other hot topic is there but this, while we all stay at home?
Right. Oh my gosh, yes.
How you doing? How you doing, sister?
I'm doing well. How about yourself? I'm doing well. And you were saying earlier how crowded the stores was yesterday. I ordered some food at a restaurant earlier, went to pick it up, and I was gonna stop by the grocery store to get some orange juice. And I looked at the parking lot and I was like, nope, not today, not on the day.
You can't get grocery in pieces. You got to get it all in one big bunch.
I ordered it online, but it doesn't come until Wednesday. I just wanted some orange juice for a mimosa this morning, but I that, so it worked out. But I was like, there's too many folks. Folks are not. Everybody was at the store. I guess they wanted their Easter meal, but whoa.
All right. Well, we're going to dive right into the conversation. Yes. So if you are watching, we want you to get involved in the comments today. We want you to ask your questions. Watch on our HeyyySister page so that your questions can come up in the feed so we can bring them onto the screen. Hey, Jody, we're glad to have you here today. Let's say hey to Jody.
Hey, Jody.
Please share this, start a watch party. So first things first, we want to clear up. We want to talk about the virus versus the disease, because we had a little pre-show talk, but we really want the people to understand what is coronavirus, what is COVID-19. Is there a different and so please share with us.
Sure. So the same way HIV is the virus that causes AIDS, the coronavirus is the virus that causes COVID-19. So that's the easiest way to think about it. So COVID-19 comes from CO from corona, VI from virus, and 2019 was the year it started. So COVID-19 is how they came up with the name for the disease syndrome.
Okay. And so tell us about, because my sister had asked the question when we were in the pre-show about you were talking about SARS-N2 and
So the thing that I want people to understand is that coronaviruses are a family of viruses, if you will. Okay. This particular coronavirus is new, which is why they call it a novel coronavirus. But other types of coronaviruses have existed. For example, MERS was a coronavirus that happened a few years back. SARS was a coronavirus that happened a few years back. Now, what that means is SARS, MERS, this new novel coronavirus are like cousins. They're not the same thing. They're not interchangeable, but they're in a similar family.
Okay. All right, that's very good. Thank you for that clarification. Now let's talk about what happens when it gets in the body. So
Okay.
we watched Chris Cuomo. He talked about what was happening, his symptoms, and how he was fighting it, and with deep breathing exercise, and all of this different stuff. But what happens once you have the virus and it starts attacking the body? What does that happen? What does that look like?
So without getting too far into the weeds, the easiest way to think about it is that typically the virus is spread by someone having the virus, and you touch them, touch something they coughed up or something from them, and you touch your face. That's why they're saying to you, don't touch your face, because when you touch the face, you're actually taking the virus from wherever it is in your community and you're putting it into yourself where it's going to go and do the damage. Okay. Yes, it's true it can live on surfaces. Yes, it's true that in theory you can aerosolize it and it can fly out. But the primary way you get it is someone coughs on their hands, shakes your hand. Now it's on your hand. You rub your eyes, you rub your nose, you rub your mouth, and boom, there it goes. Okay. That's why they're talking about social distancing to keep people apart. Cover your cough into your elbow and wash your hands. And then lastly, don't touch your face. Because even if you're surrounded by viruses everywhere, if you never take that step to take the virus from the community and put it in your face, there's much less chance you're actually going to go on to develop the disease. Now, once it gets into you, it attacks your respiratory system. That's the system you breathe through. So the easiest way to think about it is your nose and mouth are connected to big passageways that go down into your lungs. Right? Those big passageways all have names. We don't need to deal with that right now, but those passageways are lined with cells that the virus goes into and starts to cause the problem. The people that get ill are people that, number one, get ill because the cells that are being attacked by the virus don't do their job well. And secondly, the immune response of the body trying to fight off the virus sometimes revs up so badly that it causes other problems.
Okay. All right. And so let's talk about some of those symptoms, because we've heard this whole cascade of symptoms from loss of taste and headaches. And so some of the obvious ones, fevers, chills, you know, and distinguishing them, because we pre-game in this thing, we talked about the allergies, you know, the
allergies, flu,
super high, allergies, flu, common cold.
The common cold.
Talk about the difference in the symptomology.
The challenge is that most people won't be able to sort those things apart very well.
Okay.
Because most people don't know the difference in terms of how those things come together to be able to definitively say, this is a cold, this is flu, this is SARS, and this is allergies. What I will say to you is that as a physician, and what we're looking for is we're looking for a treating pattern. Okay. A pattern. I will say for myself, I live in South Louisiana. It is the springtime and everything known to nature is blooming. It is impossible that I'm going to walk around without heavy medication for my allergies. And even with that, I'm going to have some challenges with my sinuses. I'm going to have some challenges with postnasal drip, which are going to make me hoarse and are going to make me cough. The difference is that's going to be a wet cough. And expecting the lay public to know the difference between a wet cough is more likely to be allergies and a dry cough likely to be associated with COVID. Too far.
Okay.
Okay. So I try to say to people, it's a constellation of symptoms. What we're looking for is we're looking for fever, number one. There are people that have COVID infections without fever, but that is really the hallmark. Secondly, people with significant COVID infection have trouble breathing. And by that, I mean their oxygen levels either drop or they physically have problems with the process of taking a deep breath in and letting that breath out. Those are the sorts of things that really make this go from, yeah, maybe I feel a little bad, it might be something, to, oh my gosh, this is something that I need to be motivated to directly deal with.
Okay. All right. Sister, do you have a question about to dig into this a little further before we go to the next topic?
Well, I you know, like when HIV becomes AIDS, sister, you were saying it's because the T cells drop to a certain level, but most people outwardly understand it as, oh, that's when a person has pneumonia or that they have something else. So is there some outward thing? So is it when people have pneumonia that they really now this COVID disease, they can't?
Good. Excellent question. And I want to spend some time here because when you are really, really ill with COVID, you're not actually spreading it to anybody because you're in the hospital.
Mm-hmm.
When you really have a moderate case of COVID where you are just really not feeling great at all, but not bad enough to be admitted, you're not walking around meeting people and spreading it to folks because you're laying in the bed trying to get right. Most of the people that are spreading this disease are either asymptomatic or have such mild symptoms they don't notice it and they feel fine. Mm-hmm. And I think that's what's really hard for folks, because most people think you're only sick if you broke down. You're only really having problems if you can't do anything, you can't talk, you can't breathe. That's really not it. You're able to spread this disease process even when you feel well, even if you get a very mild version of the disease. And so it's very difficult for you to look at somebody and know, ooh, they got it. Mm-hmm. Because the people that you can look at and see they have it, they're so far past that they're somewhere in a special environment already.
Mm. And so you're saying the vast majority of people, when they become severely ill, they likely already had some other underlying health, because you said
no, that's a different thing. That's a different point. And I want to come back to what I'm saying is that most people that are spreading COVID don't know they have it. Mm-hmm. Most people that are spreading COVID feel fine because they don't have the worst of the symptoms, mm-hmm. which is why it's so hard to say to people, don't go to church and be around a bunch of folks. Well, everybody looks good in church. Well, those are the people that spread it. They look good, mm-hmm. but they still have a virus. Mm-hmm. That's 80 to 125 microns. You need an electron microscope to see it, but it's there. And they don't know to sequester themselves because they don't feel bad. And I think that's really, really important for people to understand. The folks that are spreading this actually feel pretty good.
Mm-hmm. So you were breaking down earlier, you were talking about those percentages. So there, you said the majority of people are feeling fine. They may have a mild infection. They may not even know they've ever been infected, right? And that's you said about 85%. Can you break the percentages down again?
Yeah, about 85% of people, so 8.5 people out of 10 that get COVID are going to have mild symptoms. And now when I say mild, that means you have something that exists, but not so bad that you need hospital-based care. Okay. So people on the sort of more advanced end of these mild symptoms may have muscle aches. They may feel a little tired. They may have a fever, but they're still mild in that the help that they need can come from their own pantry and come from their own medicine chest. They don't need someone that's a professional to tend to them. So 8.5 people out of 10 are like that. Of the people left, about 6% of people have a critical illness from COVID. And what that means is 6 people in 100 that get infected will have an illness so severe that they need some sort of breathing mask on. They may even progress to having a breathing tube put in and be put on a breathing machine. And then in terms of people that die from COVID, and I want to spend some time talking about the deaths because there's some healthcare disparities to talk about there.
Yes.
Originally, they said about 1 to 2% of people, so 1 to 2 people in 100 that actually get infected end up dying. And so how does that compare? The common flu affects way more people, but it only has a death rate of about 0.1 to 0.2%. So this is an order of magnitude more deadly. It's only 1 to 2%, which you might say that's small numbers. But if that 1 to 2% is your mama, your grandmama, your daddy, your uncle, you feel that 1 to 2%.
That's the part that we need to really emphasize, because since the start of this, like, that is one of the things that I've heard more often than not. It's, well, the flu, more people die of the flu than do this. Or, well, more people get ill every year and we don't take those same measures.
Let me explain it to them like this. More people get injured and die in car wrecks than on motorcycles. But if you get in a wreck on a motorcycle, you're more likely to die. So because you don't have anything around you.
Right.
So you can't say, well, I don't have to worry about dying on my motorcycle because more people die in car crashes. That's apples and oranges. Because you can have a nasty car wreck in a car and still live. And you can have a moderate car wreck on a motorcycle and be out of here. So I think the same way, more people have the flu. So the number of people affected is much higher with the flu. However, that translates only into 1 to 2 people in 1,000 dying from the flu, whereas COVID, 1 to 2 people in 100 are dying.
Okay, thank you for breaking that down. Now that is going to lead us into these health disparities. There's been a lot of conversation about the African American community specifically. I have been very uncomfortable with some of this conversation. I was very uncomfortable with the way the Surgeon General spoke at the last Friday's press conference. And no, I don't think he's racist. However, I think there's a segment of the population that heard his message and they're taking away, oh, that's only affecting Black and brown people. That's why I saw so many people out here
So
moving around.
What's crazy is that I want people to understand that COVID is not immune to the disparities and inequities already built into our healthcare system.
Preach
we
on
already
it.
know that Black people are less likely to be insured. Their uninsured rate is much higher than the general population. We already know that Black people are less likely to have trauma centers that have the specialists that treat these kinds of diseases in their neighborhood. We already know that because you don't have a primary care physician, you can't get the prescription to get the testing done early. So there's a barrier to getting tests. Aside from those healthcare structural things, Black people are only able to work remotely 16% of the time, whereas in other socioeconomic groups that have more options, 61% of those people can work from home. So we have Black people that have historically been marginalized in the healthcare system. They are the essential workers that are driving our buses, that are delivering our packages, that are manning our food stations, that are driving our cars, that are driving our subways. So they're out there on the front line with no protective equipment. Okay. So Black people are more likely to be exposed because they have to choose between working and trying to social distance to keep themselves safe. And when they get exposed, they're less likely to be able to access healthcare to get a speedy and aggressive response. That's translated into 100% of the deaths in St. Louis are Black people. 70% of the deaths in New Orleans are Black people, even though our population, I take that back. 70% of the deaths in the state of Louisiana are Black people, and our population is 32%.
Right.
Okay. And those numbers are repeated in Chicago, Milwaukee, Detroit, and the larger state of Michigan. And we don't have them for some jurisdictions. Why? Because they're not really reporting the stats on race. So places it hasn't come out yet, it's not because it's not happening, it's because we haven't counted. And I really credit my friends, Black physicians on the front lines on Twitter that really started this conversation 2.5 weeks ago, saying what I'm seeing come into the emergency room and what I'm transferring from the emergency room to the intensive care unit looks different than people are talking. And that pushed this group of folks, doctors, Black doctors, to ask the question. And so when you say, why do Black doctors matter? That's why Black doctors matter. Because if there hadn't been any Black doctors 2.5 weeks ago noticing this and pushing this agenda, we wouldn't even have the data we have now to discuss this as a public health issue.
And I would add a little bit to that because we know the Surgeon General is Black, but unfortunately he obviously spoke in a way that seemingly echoes some of the sentiments of others. So not only having Black doctors is important, but having Black doctors who remain connected to the Black community.
Have a voice. Now, I want to tell you something that's really weird. Before I really ramped up my discussions of this publicly, I had a conversation with a good friend of mine. He's a healthy, muscular, gym rat kind of guy that lives out of LA. And he basically said, well, all these Black people are dying from COVID because they're fat. And they're fat and they're obese and don't care about their health. And it blew me away that someone that I consider a friend, somebody that tends to be right on most of the issues, was basically saying Black people are dying of COVID because they're fat and don't care about their health. That answer, I think, for some people is much easier to digest and process than we're dying because the system was built to shut us out and it's operating as intended. That's easier to manage and deal with. To say, you know, if you didn't have that asthma and that diabetes and that heart disease, you wouldn't be out there bad. There's a time to talk about that, and there's a time for personal responsibility, but I don't believe in shaming the dead.
Absolutely. I agree 100%. This conversation has really been bothering me because of that there was no conversation about they are the essential workers, and we're
Mhm.
also seeing it with the Hispanic community. You're also
Yes,
seeing it in the Native American
Native
community.
American. Oh my
Um,
gosh. The
tell us.
Native American communities were protected in some ways because they were isolated on in their geography and their living conditions.
Mhm.
But of course, all these people with vacation homes out in the country somewhere, they're going to go and hide from all the pestilence in the big cities out in these rural areas. And what do? They take the pestilence from the big cities out there to the rural areas. And it's really interesting. And it's an upshot of affluence and privilege.
Mhm.
You know, you could have sheltered where you were, but because you chose to try and value yourself, you ended up spreading it to people that would have never seen it.
Mm.
And I think that's interesting. That's fascinating. And I think the other discussion we have to have is, as Americans, we are taught to be rugged individualists. We praise the person that got a wagon, a horse, and threw their family in the back of that wagon and drug them from Virginia out to Nevada and made their new way. They claimed a piece of dirt and they built it up from nothing with their own hands. That ingenuity and that drive has merit. However, that is the opposite of egalitarian. You're not making decisions based on what's best for the society. You're making decisions what's best for you.
Mhm.
So what we're hitting up on this COVID stuff is that if you don't know anybody personally that's affected, or you don't have anybody, any way that disease is touching you, why should I social distance? I'm safe.
Mhm.
That's really not hitting me any kind of way. It's just killing Black people in cities that I don't go to no way. So why should I deal with that? Well, viruses don't respect lines, state lines. We don't exist as Black people in complete isolation from white, Native American, Latino, Asian, and other people. So if we are going down, we are going to infect other people as well. So this isn't a Black disease any more than it should be called the Chinese virus.
Amen.
Because all of those things are coded language to make these problems otherized.
Mhm.
And when you make them otherized, people are able to turn on their blinders, shut down, and say, doesn't affect me and the people I love.
And then, so to that point,
Oh no, I think I hit on something there, huh?
Well, listen, I agree with you 100%, but I also see there's also this myth about that rugged individualism where you did get that wagon and you did go out west and you were able to be a what do they call the people they planted their stake in the land. I can't the word I'm looking for. I'm missing the word I'm looking for, but nonetheless, but that was done at the expense of people who were already there. That could not have been done without displacement of some people. That could not have been done without taking people from their native homeland and bringing them over here to build this country. So that thing about rugged individualism has been a lie and a myth from the beginning, because you did not do that of your own volition and of your own skill and talent, because that foundation had to be laid for you by killing, infecting, displacing other people.
Well, this is my concern. So here's how this has now been. First, it was labeled, like you said, a Chinese virus. Now it's this. I believe there's this belief, right, that it is only going to impact Black people. But like you said, I mean, we do interact with all sorts of people, and there is the structural racism that is embedded in the healthcare system. Do you think now that people think that it is only going to impact one group because they're fat or they don't exercise or they have underlying health issues, do you think the response and the drive to get a vaccine is going to be as imperative?
I do. And I see there's two parts to this, because you remember when this first came out, there were some people that actually got up on TV and said the melanin in our skin protects us from this virus.
Right.
You don't see anybody on the continent of Africa coming down with this virus. It was this whole thing about the magical Black person, the magical thing.
Negroes, yes.
The magical Negro that just we float above pestilence because we're not really human. That sounds like a compliment, but that dehumanization really sort of is the first step to make people that are already vulnerable less vigilant. Okay. Okay. Now, in terms of how this is going to translate, there's going to be a lot of money in coming up with vaccines and curative measures for this. And so if we don't know anything else about America and our capitalist system, people are going to chase that money and try to get it. So I don't think there'll be a sort of relaxation to try and get towards cures and vaccines.
Okay. What
I do think we have to be careful of is I think we have to be careful of labeling this as a Black disease after we initially said it didn't affect us because of our magical Negro properties. And we also have to really avoid making this into something that it's not. This is a representation of systemic racism. This is a representation of health inequities. This is a representation of differential outcomes. So it didn't create them. It just underscored them and made them more visible to the people that are right now in front that need to see it. Yes.
Okay. So word I was looking for, one of my people in the watch party put it in there. Homesteaders.
Okay.
The homesteaders. Yes. So there's a question here from one of those people who are on the my watch party. It says, given the lack of testing, and we're going to talk about testing here in a minute. Given the level or lack of testing we have and backlogs of those, what concerns do you have about discussion of laxing, distancing, and sheltering in place guidelines going forward? Now, this is one of my friends who's in Texas, whose governor is like, oh, we're going to start kind of relaxing things. Even the governor here in Florida. And I'm like,
oh, that governor in Florida that says nobody gets this if you're under 25. I was like, oh my goodness. That hurt my soul. But we're gonna leave that where it is.
Listen, because again, like you said, it was a Chinese virus. Then it was like only if you're over 65, and then no, Black people can't get it, and everything that is like, stop it with this foolishness and just let people who are experts speak. But let's talk about this. Let's talk about why social distancing works and what are the concerns with laxing these measures too soon.
Okay, so the best explanation about social distancing I've ever seen was there was a a video, and you all might have seen it on Twitter, where they have all these mouse traps on the floor with ping pong balls on them. And the mouse traps are sitting right next to one another. And they drop a ping pong ball from the top into one blank mouse trap, and that sets off a cascade of mouse traps exploding in the whole field. They repeat the same thing, but they spread the mouse traps apart. And all that happens is the mouse trap, is the ping pong ball falls down, it snaps one mouse trap, and all the things around it are just fine. It was a visual representation of spreading people apart, keep people from infecting one another. And what I think is an important thing to say is that we don't have, as a population, any immunity to this disease. So this disease is going to move through our population how it does. What our job is to keep it moving through the population in a way that doesn't overwhelm our healthcare system.
Right.
So if 15 people are going to get this, all right, we just want to make sure if we only have 5 ventilators, that all 15 of them don't get sick at the same time. If you have 15 people that are going to get sick from something, but you spread it out so there's never more than 4 or 5 people that are sick at one time, you never outstretch what you have to care for them, right? So that's what we're doing when we're talking about flattening the curve. We're not eliminating people getting infected. We're controlling that process of infection so it doesn't tear through the country in such a way that we can't respond.
Right. Right now, the demand is higher than the supply. The supply of PPE, the supply of ventilators, the supply of
everything. And so what we're looking for on this curve is 2 things. And again, the part that's hard about all of this is that this is all the stuff in biology people fell asleep on in high school, and all the stuff in math nobody wanted to deal with in probability and statistics. That's what this comes from. Okay.
I love that. Say that again, because for everybody who is homeschooling their kids and they think that, oh, you're never going to use this math in your life. See, you all go for the biology people. I'm the engineer here. So when you tell
and public health, Holly, you hear me? I got a public health degree too.
Yes, say that again, because folks need to understand how this comes about.
So when you talk about flattening the curve, that's calculus, okay? Because the area under the curve represents the number of cases. The area under the curve and a pointy curve and a flat curve is the same. The shape is different. And it's a different shape that allows us to control how the disease process moves through. But if you never understood calculus, that sounds like Greek to you.
Right.
Okay. And
come on for the education, because the education secretary don't even understand flattening the curve. And not to mention the man who can't even speak in complete sentences. Holly.
Yes. And you know, and when you get past that, talking about stuff like relative risk, you can't talk about relative risk if you don't understand statistics. You can't understand why people said groups of 100 or more were problematic at one point, but that number was stepped back to 20 and stepped back to 5 based on what the prevalence of the disease was in the larger population. That's statistics. Those numbers weren't picked out of a hat. That's not where that came from. And so if you don't understand it, it lends itself to all of these conspiracy theories where, well, they just don't want Big Mama to enjoy her family. This is to break up the Black family. Child, no, it's not.
All right. Oh my goodness, that you spoke a word right there for sure.
Talk about testing, because we got to get to these conspiracy theories.
We're gonna get to testing. We got to talk about testing. We're gonna talk about the next wave. And then first, let me go ahead, because I spelled your name incorrectly, and so I need to make sure I'm pronouncing. It's Shoals, right? That's how we say
Correct.
it. Okay, so I spelled it incorrectly. Dr. Maurice Shoals. This is how you spell it. I'm gonna drop in the comments in a minute here where you can find him on social media, as well as his website, so you can go and get this education for yourself as well. But let's see. Let's talk about testing. A little bit more about testing. So we hit on it a little bit as it relates to lax. Before I get to testing, or maybe this is related, because probably for the last 3 weeks, anybody that follows me on Facebook knows I have been talking about we need a coordinated federal response. We need a coordinated federal response as it relates to testing, as it relates to distribution of goods, as it relates to the supply chain. I mean, you got farmers out here talking about they're throwing away crops because the supply chain is messed up, but we got food banks that don't have food. Like, what is happening here? Like, this is not making sense. Coordinated federal response. Can you speak on that before we get into this testing?
So part of whether you are a big government liberal or a small government conservative, there are some key things everyone agrees the federal government should do. It should be there to respond to things that are an order of magnitude beyond what local jurisdictions and municipalities can deal with. Okay. And if a pandemic does not qualify as something beyond what a local jurisdiction can deal with, I don't know what does. So to me, this falls squarely within the purview of the federal government to not be in charge of everything, but be in charge of overall strategy and coordination.
Well, thank you for that. Now let's talk about
testing.
Let's talk about testing. I want to talk about, so there's diagnostic testing, which we are woefully behind on, and they keep saying, oh, we got more tests going on, more tests going out, but clearly,
we do.
Okay, so that's diagnostic. And then there's this antibody testing that, testing antibodies for being a possible treatment option. So let's talk about those different types of testing and where are we with both?
So with testing, the gold standard is PCR. Everybody's sort of familiar with that from, that's the DNA test that we first learned about to say who's the daddy in the birth thing.
Mm-hmm.
So basically, you're actually testing the genetic material and looking for genetic material representative of the virus. Okay, there's different companies that are coming out with ways to do that test. Some tests you use a certain portion of blood. Some tests you use a swab from your nose. Some tests are developing that you can use saliva for. So the testing, that really is an explosion of options, because more and more people are figuring out ways just to understand, can we figure out who has this and who doesn't? And I want to take a minute to say there's no test that's perfect. Okay, this gets your public health and your science there. No test is 100% specific or sensitive. Okay,
Mm-hmm.
What does that mean? 100% sensitive test means it's gonna capture everybody that's actually positive with the disease. Specific is how many people have something else, but they test positive on this particular test. All right. These tests are pretty good. They're coming up with, but I think it's important to understand that no test is 100% sensitive and 100% specific. Now, that being said, it's really interesting not just to know who has it, but to understand who doesn't have it. Like, who are the people that should, by all rights, have COVID oozing out of everything and they're not positive? And what is it about them? Okay,
Mm-hmm.
That's just as important as understanding the people that are dying. What is it about them that made them catch something that 8.5 people out of 10 don't have any problems with, that requires hospitalization, but it took them all the way to the grave? Mm-hmm. Those sorts of things are really, really important. There's chunks of testing that some of which are paid for by the federal government, and they're administered through the state and local municipalities. So here in New Orleans, we had some testing that was done by the city at checkpoints. That was paid for by federal money that came down through the cities. That money's being pulled back and those centers are being closed. Other tests are happening through each of the hospitals and doctors' offices. So it's not a federal funded thing. It's something you go to with your insurance or your money and you pay for and you get done. Okay, so those are the two sets and types of testing. They tell the same answer, but different people have access to different sets of tests.
So wait, say that absolute and specific, you said, right? You said absolute and specific?
Sensitivity and specificity when I was talking about testing.
Sensitivity and specificity. And so which one is paid for by? I'm sorry. I heard the words, but now that you said,
let me back up.
So there's two different things he talked about.
Sensitivity and specificity has to do with how the test performs.
Yes.
How the test performs and how accurate it is. Right. In terms of how the tests are being rolled out into the community. One set of people that are testing are the hospitals. Hospitals and doctors' offices are testing. You can go to, here in New Orleans, you can go to New Orleans East Hospital, you can go to University Hospital, you can go to the VA Hospital, you can go to Ochsner Hospital, you can go to East Jeff, you can go to West Jeff, you can go to those places and get tested, okay? In addition to those places, there are federally funded areas that do drive-up testing.
Right.
Those federally funded drive-up testing, there was one at the Hilario Center, there used to be one at the Lakefront. Those things that are not hospital-based testing, but federally funded tests, that's money that's coming from the federal government to the state and local municipalities to test broad sections of people that either can't go to the hospital, don't have access to the hospital, and it just opens up the pipeline for more people to get tests.
So let's clarify that.
So if they don't have insurance, then they can't go to a private hospital anyway to get the test.
You can, in an emergency, no one can turn you away, okay?
Okay.
What the big barrier is to getting tested is that a lot of places you have to have a doctor's order. Okay. You can't just walk up and say, test me, I'm here.
Okay.
It doesn't work like that. And so if you have a primary care doctor, I can call up and say, hey, doctor, I'm feeling crazy. These are my symptoms. He says, yep, that sounds like you're at risk. Let me write this prescription for you to go on and get tested. Okay. Then you can go to any one of those centers at a hospital. You can go to one of the drive-up community-based ones. You can go wherever. So the real barrier is not money itself right now. The real barrier on the front end is who actually can get a prescription to get the test done. That's the hurdle.
And if you don't have a primary care physician that you have a relationship with, that you see on a regular basis, that you're having these conversations with, who you can even do a telemedicine consult with or pick up the phone and call, you are going to have a battle getting that done. Or
Yeah.
you have to present to the ER or present to an urgent care. You have to go somewhere.
Yeah.
But we have a couple of questions. One says, if
I
you're
see that one from Lakeisha.
Yes.
And you know, her question is, if your insurance pays for the test, can they still turn you away with one or two main symptoms? The problem is that there is not one symptom that is, I'm gonna use a fancy word here, pathognomonic for COVID. What that means is there's not one symptom that means COVID and only COVID. There isn't one of those things. So because of that, you look at not just one symptom, but the constellation of symptoms the person has to decide where they are on the testing strata, whether or not they are really need to be tested or not. For example, if somebody is strongly suspected of being exposed, they are on the back end of their infection, not having any problems, not really having any trouble breathing, and they don't need to be hospitalized. Why would you need to test them? Presume they had it and move on, because all that's doing is that taking a test away from somebody that we don't know, and it will make a difference in their treatment process. Okay. And so there are times when you have to presume positive. Now, if we were in a situation where we had more than enough tests per people that needed to be tested, you could dole them out like chiclets. Everybody can have one, but we don't have that. Even when we got enough tests, at one point, the reagent that you actually used to resolve the test, we didn't have enough of that. So even if I had a testing kit and had the swabs to get in your nose and get the testing, we didn't have the reagent to dump on there to actually do the test. So that's when it comes down to availability. And you better know that if there's a scarce resource, rich people, powerful people, people with access get it first.
Right.
So it's no surprise to me that the entire NBA and coaches in the NFL get tests, but I have friends that can't get tests in their healthcare centers.
And I had a question on my page was how from Jane Price, she asked how long does it take to get results, and I've heard everything from 5 days to overnight. So I need to understand.
It depends on your capacity to process the test. So if you're in a place where they can process the test, you can turn that thing around in hours. If you don't have the capacity to process the test or don't have the kind of test that can resolve in hours, it can take days. Okay. We had a big bump in the number of positive cases at the end of last week, not because a bunch of people were infected all of a sudden, but we ran all the backlog tests.
Yeah.
So the test got done, but they had to actually be run. You know, and so all these are processed. Just because somebody puts that pipe cleaner in your nose and puts it in the thing and sends it off, that doesn't mean the test is actually done. And so that's part of the delay between when the person actually gets the test done, when it's actually run, when it's read and interpreted, and then when the results are given back to you.
And people are dying in between that, because if it's taken 14 days, some people they're getting tested and they're waiting on their results and they're dying before they get their results.
You know, and it's something. It's real something. I would say the 14-day things comes in because we know between 7 and 14 days is sort of the course of the disease process. What we don't exactly know is that once you get it, are you done with it forever? Wow. No, or does it pop back? And the easiest way to explain that is the common flu changes so quickly that we have to make a new vaccine for it every year. Whereas something like the measles, it doesn't change quickly. So when you get vaccinated against that as a child and get a couple booster shots several decades later, you're still covered, okay? Because even though the measles virus is very infectious, it's not something that's constantly shifting and changing. Whereas that flu is constantly shifting and changing. In looking at COVID, it looks like COVID is not constantly shifting and changing. So when we do come up with something to treat it, it's going to be durable and last, as opposed to be something that'll last for a little while and boom, the virus will outsmart it.
Okay. So then let's talk about that, because we're going to, go ahead, finish your point.
Yeah, you were asking about the testing for antibodies, and that's the second piece. Okay.
Yes.
I'm reading your mind. I'm following you.
Yes, because that's related to that treatment possibility.
Yeah. So once you've actually been infected with COVID and gotten over it, your body has floating around in it antibodies against that virus. It's sort of like, now that you've been infected and survived, your body can't be jumped on by that same virus the same way again. And so what people are doing now is finding folks that have had infections of COVID and then taking their plasma and spinning it down and extracting those antibodies from their blood and thinking, okay, in a test circumstance, if I had somebody that was critically ill with COVID infection, they're on a breathing machine, you know, on the edge of death, and they're really having a hard time, and all the things we're doing for them aren't working very well. If we give the antibodies from someone that has beat COVID to that person, will those antibodies neutralize the virus in that person struggling for their life? That's what we're working on right now. It is not to the point where we can give those antibodies to a random person and it makes them immune. We're not there yet. Okay. That's what the whole vaccine process is for.
Okay. All right. So then let's okay. So thank you for clearing that up, because I want to get into this treatment piece.
Really quickly, there was a question on my
Okay, go ahead.
Sorry. The comment was the folks from Jaime Sanchez. Hi, Jaime. The folks in nursing homes and employees of these homes. I'm not sure how those vulnerable are not automatically done. So why is it that healthcare workers and those who are most vulnerable are not being automatically tested before they have to get in front of, you know?
So what they're doing is they're screening you before you go in there. So when I go to the hospital to work, when I report to the hospital, they take my temperature. And if my temperature is above 100, now a fever is not unless it's above 100.7. But if I'm close to a fever, I'm done. I can't go that day. Okay. So they're doing aggressive screening. Secondly, if you have any active cough at anything, you can't go. You're not allowed to go. So what they're doing is, rather than testing and verifying, because that test is only as good as the last person you were around. So I could take a test today and be negative, go get infected tomorrow, and that'd still be a problem. Mm-hmm. So it doesn't really do any good to chase testing in that way. You want to make aggressive, cough into your elbow, wash your hands, don't touch your face, practice social distancing when you're taking care of or have a process where protective equipment. That's what you do, and you monitor symptoms to make sure that people aren't exposing folks. And I think similarly to healthcare systems, they're doing that in essential workers, like at the grocery store. All the people that are working at the grocery store, God bless them for making sure we all have food to eat while we're sheltering in place. They're screening them when they go to work. And they're screening them sometimes twice a day. And I think that gets at whether or not you feel good or not, what are your symptoms? Not how you report them, what do you have? And that's really useful.
Thank you.
All right. Thank you so much for that. So let's talk about the potential treatments.
Okay. We don't have any. There we go.
All right. Good. Because
short question. Easy. There are none. There are none. No, I won't even say their names because I don't want to give credence to that. Those medications are desperately needed for people with critical diseases in other areas. Those medications have other side effects like causing funny heartbeats and arrhythmias that can be fatal in up to 30% of the population. No, there is no treatment for this right now. We're working on that.
Okay. And so that's the one treatment that they're talking about. That there's another one that's given out like candy, but then that's why we also have a lot of antibiotic resistance as well out there.
Well, antibiotics go with bacteria. These are antivirals. And the reason that antivirals can't necessarily be one exchange for the other is the way the antivirals work depend on the mechanism of how the virus attacks and gets into the cell. And typically what you're trying to do with a medication is block how the virus attaches to a cell and then is internalized into the cell. And that's a different mechanism for each virus.
Right. And so then why the Z-Pak is being used? Because that to me,
it shouldn't be used. A Z-Pak is Zithromax. That is an antibiotic. That does not treat viruses at all.
That's what I know, but that's what I'm saying. They've been talking about using the hydroxy, whatever. I'm not saying
any of them words out loud because
and the azithromycin, and I'm like,
none of those things are useful. And so somebody might say to you, well, why is it I got a Z-Pak for my pneumonia and this infection causes pneumonia in some people? There are viral pneumonias, there's mycobacteria pneumonias, and there's bacterial pneumonias. Those are three different types of things that cause pneumonia. You can't use the same medicine to treat them all. And how about, here's another kicker. You could start with a viral pneumonia and develop a secondary bacterial pneumonia after that. So those people started with a viral process, got a bacterial process that you ultimately can treat with antibiotics, but those antibiotics don't do anything for the viral infection. No,
So there's no treatment.
Thank you.
That's what we need to just, that
I put it that we don't have any potential treatments, period. None.
period with a T, period.
I probably should have added
with
the
a T.
Yes.
None. None, Ghost Rider. Never have. None. All right. So we have this one is a little lengthy from Lakeisha here. It said, is it true what Dr. Burke said that the machine to test the healthcare workers in the hospitals are not in working order? Thus, why only 88,000 instead of 1 million have been put through?
What machine? I'm not exactly following what machine she's talking about. The testing issue is a testing issue. Those are testing kits that run through the laboratories of either your hospital or some laboratory processing thing. In terms of, is there a way for people who are put on ventilators to not go on their backs? Yes, there's a certain way that people manage folks on ventilators. Sometimes they put them prone rather than, which is on your stomach rather than on your back. There's other treatments where they use different kinds of ventilators, either oscillator, or some of them might even progress to a type of ventilator that's even more aggressive than that. But again, that's really how you're managing somebody that already has proven to be critically ill. And so that's not really a useful conversation for the larger discussion, because how you're going to manage what type of ventilator on what type of critically ill person, that's really a little bit beyond what we're going to talk about today.
Okay. All right. Let me go here. Okay. So let's talk about, should we expect the next wave? So right now, here's the thing. If we do this laxing that some of these people are itching, to get everybody back to work. And I'm like, what they gonna do? Yeah. What they gonna do?
So again, this gets back to that math thing. Because we aren't giving a population of people immunity to this disease. Again, the point of social distancing, the point of all these measures is to control how this disease moves through our population. If we turn the spigot back on and has a population remixing rapidly, all we're going to do is reignite the first wave. Okay? Because we still aren't immune to COVID. We still are susceptible to people that have it, and people that have it still aren't symptomatic when they pass it along, by and large.
We still don't have a treatment.
And we still don't have a treatment, and we still have no vaccinations. So there will be another wave. Again, the key is to gradually relax this stuff in a time and at a place that makes sense, so that when this wave comes, again, it doesn't outstrip the resources we have in our hospitals and centers to actually take care of the people that are ultimately sick. Because what you don't want is to have people that could have been saved had we had the appropriate equipment. But because we rushed it so fast, there were more people that could have been saved than equipment to save them. And that is a travesty we shouldn't have in a developed nation like this.
Right.
We got so many travesties in this developed nation. Listen. Can we talk about the travesties in this developed nation?
You know, this is Easter Sunday. He is risen. I put on my good pastel blazer to support that. I see your beautiful yellows on there. I mean, I'm trying to stay in a headspace where I can do my work and be positive.
Amen to that.
That don't mean I can't tell truth to power. Hold on one second. My cord is running out of charge. So I want to go get it.
Okay.
So I don't lose y'all. But I can tell truth to power. But I'm gonna try to sit in a different headspace right now.
Yes, and I agree with that. Well, what we gonna have to take you to that other crazy headspace for a minute. But while you do that, let's see if we have any questions on our any other questions, guys. We're gonna get into myths and facts here in a minute. So we have one on my watch party from Elaine Shanklin, another Thibodeau native, another Louisiana girl, who says,
"Hey, Louisiana girl.
Thank you for this segment. The explanations were very beneficial." We have one comment from Rosalind Ross. That's a Mississippi girl who's out in California. She says the travesty in our federal leadership. And then Stephen says second wave of the Spanish flu killed more than the first wave did, which we know, why this is so very, very concerning about all of this talk about getting people back to work, about laxing guidelines, about Oh, we might send the kids back to school even if it's just for 2 weeks. I ain't sending my children back there, Governor. I'm sorry. It's
And
a
you know
wrap.
what's crazy is that children aren't immune from this, but children clearly have a much more mild course with this disease. So if you look at death wise, the relative risk of kids is way less than adults. So sending kids back to school is not necessarily because I'm as worried about the children, but the people that actually support the children, the people that teach the children, the people that cook for the children, the people that clean behind those children, that like those people are at risk.
Mm-hmm. So one thing, so we're gonna get into myths versus facts. So out the gate, do you think the conversation about lax is related to the myth of it being an African American disease?
No, because remember when this first started, they were saying Black people weren't susceptible to it. We were the mad Negroes. So like just barely a month ago, you know, nobody on the African subcontinent had it. No Black people were dying from it. So we were immune to it. So, you know, I think people shift the narrative to meet whatever thing they want to have met. And this doesn't represent something new. It just represents the latest example of healthcare inequities that we have in the United States.
Okay. Myth versus fact. It's the 5G.
Wait, let's know before we go to 5G, because 5G is going to be a deeper conversation.
No, I can shoot the 5G down real quick.
Go.
It is not related to 5G, and we done. Done.
Period with a T. Period.
With a T. No.
Period.
And I was talking a little earlier when we were prepping for this, is that if you look at where towers are for 5G, they tend to be located in populated cities and centers that actually have the most number of people because you have the most need for a 5G network. Of course, if you overlay that onto areas that are endemic and the most dense, they're going to have 5G towers because they were actually serving a population that's dense. And an infectious process is more likely to explode and move through a densely populated area than one sparsely populated. So it's sort of like these two things exist, but have nothing to do with one another.
Right. Okay, here's another question that is one of these myth versus facts is dispelled from my watch party. It says, are there any facts that lead us to believe that this virus was birthed from a laboratory?
There is no data on that right now. None. We don't know. We don't have any data on that. There's no data showing like where it actually came from, because what people need to understand is that this is stuff that we reconstruct and put together based on epidemiology and based on understanding who got sick and who didn't get sick and how it was spread across. They're going to put the case together to explain where this came from and how. But again, we didn't know this virus existed 6 months ago. It's brand new. But we
knew it existed in November and December. I'm gonna just leave it right there.
Over there. Oh, yeah. But when we knew it existed in November, December, but was it going to be like SARS that was a killer over in Asia but didn't do anything here in the United States? Was it going to be like MERS that really ran a number on some people in Middle Eastern countries but didn't really do anything anywhere else? Was it going to be like Ebola that really wreaked havoc in sub-Saharan Africa and a lot of places but didn't do much other places other than make people really nervous? So yes, we knew about it, but we know about a lot of stuff that turns out not to manifest for whatever reason.
Mm-hmm. All right, we got a question from one of your fellow physician. This is one of my fellow Xavier writes here. It says, what are the most common things you are telling people to help boost immunity?
So there is no data showing that if you take zinc or drink this juice or that juice or whatever, the best thing I tell people is practice good hygiene, be well nourished, and stay hydrated. Because if you're dehydrated, you're more likely to have problems fighting off anything. If you're poorly nourished, doesn't matter what state you're trying to fight off, bacteria, virus, anything, you're not in any equipped to do that. So my recommendation to people is stay well nourished, stay well hydrated, get your rest, and practice social distancing. Wash your hands. Don't touch your face. That's where we are.
Okay, I'm gonna go back and watch this and see how many times I touched my face during this broadcast.
You and me both.
Did I touch my face, y'all? Let me know. But let's talk about, in general, boosting your immunity. In general, speaking, in terms of boosting your immunity, maybe not for this, but what are they? I mean, I think there's the things we know, like you said, eat right, exercise, your vitamin D, whatever. I mean, what else?
No, but maintain good health. I mean,
Mhm.
I am not one that supports any particular supplement as an immune booster.
Mhm.
I am not one that has been bowled over by any data showing that if you do certain things, you'll be more have a hardier immune system. What I know is people that are well nourished and well hydrated and in good shape do better. Now, is that a talisman where nothing bad will happen to you? Nope, unfortunately not. But that's what you can do.
Okay. Other myths, sister.
Well, so first, yeah, I have a few. We're gonna go through them real quick. But first, did this exist in animals already? So
We don't know.
I heard a bat. I heard a pangolin. Now we see the tiger has been tested positive for COVID-19. What is the deal with the animal?
So the thing about it is that, remember, coronaviruses are a family of viruses.
Yes.
There are coronaviruses that specifically affect horses. There are coronaviruses that specifically affect felines. So there are coronaviruses that evolved over the years to attack all kinds of different animal species. That exists. So again, we don't have data showing, did this jump from another animal to us? Is this something that came to us from person to person, where somebody had a particular coronavirus that mutated in them and became something else? I don't have an answer for that. So right now, people are saying it could have been from a pangolin. It could have been because people ate monkeys. Could have been from the bats. You see that bat soup over there? Again, we don't have that data showing exactly the layout. It's going to happen. We'll research it back, but we don't have it.
But we don't fund the CDC, and we don't have enough epidemiologists out there. Are we really going to get it?
That comes from the World Health Organization, actually, because they're going to trace it back to the source. So the CDC is our representation of it, but most of the developed countries have their version of the CDC, and they're doing their thing. Like, hats off to South Korea. They brought the heat in this response process. I mean, they really, really did a good job. And I think the article that they put out about patient 31, basically showing they had everything under control with the first 30 people that were infected. Patient 31 went to lunch with friends and church and was responsible for the vast majority of breakouts in the entire country.
Jeez.
And so that campaign, please don't be patient 31.
Okay. I have a question over here in the watch party. How do you feel about the video going around about warm saltwater rinse, etc., to kill the COVID-19?
Lord, my own parents texted me that, and I just had to say, Mama, please don't say it to somebody else. There is absolutely no data that gargling with salt water, warm water, cold water, up water, down water does anything with that. Those are not antiviral projects or properties. There's no truth to that at all.
But it will keep your throat soothed.
And again, and there's a place for that makes you feel well. Like somebody sent me a video of someone basically with a towel over their head, and they were like sort of sucking steam out of a hot water concoction on the ground that had all kinds of different herbs and roots and stuff in it. They were like, well, this is a traditional thing. Well, if you have any sort of bronchial or airway process, if you sniff moist, warm air, that makes you feel better. That's a treatment. We do that. Now, that doesn't cure your virus, but it surely is something you can do to alleviate the symptoms of it. So there's a place for it. Now, I don't know that it's all the stuff they put in the boiling hot water that made it smell nice that did anything, as opposed to just the boiling hot water itself. But there's no gargle that you could do to prevent this. There's no smoke or steam you could sniff to make this go away. Those are just things you do to make yourself feel better. And there's a place for that.
Right.
So in addition to the video where the young lady was dispelling how serious coronavirus was in her medical attire and suggesting that this was a 5G related issue, she also suggested that the improbability of viruses being airborne, because if a virus could stay on a surface for 5 days, then why don't we all have HIV?
Because again, clearly she flunked science. Okay. Yeah, and again, because if you partially understand things, I can see how you get all turned around about some of this stuff, But if you want to say why do people have HIV, AIDS, and other people don't? Well, everybody that was exposed to AIDS doesn't come down with it. It's only transmissible some percentage of the time, So for every 300 exposures, one of those people actually seroconvert. All right. So even being exposed to it doesn't guarantee you're going to get it. So to these people talk about why don't we catch it off a shelf? Again, if you touch it on the shelf but never touch your face, how does it get in? Ha ha. See, cough and elbow. Hey, Kendall, bring me some water, babe. Teenagers are useful for stuff.
Who is this lady? I don't want to share the video. My cousin,
you can send it to her privately.
Yes.
Privately, because I don't want any more ignorance going out, especially not for me.
Yes. But that's part of the thing. So anyone can put on a lab coat and play dress up. And clearly anyone can be president of the United States and stand before people and give out this information each and every day. So and play like you have executive. Anyway, let's go on. Any other myths and facts coming through? Let me check my watch party over here. Let's see. All right, I don't see any on my. If y'all have any more, let's get your last few questions in, myths and facts, before we get ready to wrap this up. I think in the comments I added Dr. Maurice's information, his website, as well as IG, Twitter, Facebook, LinkedIn. Feel free to reach out. Please. He wants people to reach out, connect, ask questions, because here's the thing. We have been inundated with data, inundated with breaking news, and often it's opinion news. It's opinions that is blended in with news. So then people take it as facts, and it's not. And it's creating a lot of confusion. I think it's creating a lot of laxity in behavior. I think it's also creating a lot of, for some, excessive anxiety. But it's also butted up against the reality of we are, at least myself, 2 degrees from people who have passed away. More than
I'm not too. I know them.
Yeah.
And I'm gonna tell you that this is the era of anti-intellectualism, that we're living in, where people really, really struggle with saying that person knows more about this than you do. Therefore, that person should speak as an authority. Well, are you saying I'm trash because I can't speak as an authority? No, on that subject, that's what they know about. And when you have this anti-intellectualism sort of as a backdrop, and on top of that rugged individualism we talked about a little bit before, that's sort of a societal recipe that makes certain places able to be managed easier and other places to be managed more challenging in these sorts of environments and situations. There was a NPR story I heard last week where a woman was looking at how rule following different countries were as a scale. So on one end, you had people that were like the Japanese, the Singaporeans, the Germans that are like, we believe in rules. We have a bunch of them and we observe all of them to the nth degree. And on the other end, you have people like the Brazilians and the Kiwis that are like, hey, we got some rules, kind of, we could, as long as, we're going to meet at 8-ish. And how are those different cultures responded to this process? I think that's going to be an interesting set of data. If you get a group of people that are used to following rules and say, you're supposed to do these 5 things and stay home, they're rule followers. They're going to stay home. But if you got a bunch of people that ain't accustomed to following rules like that, and you say the same set of things, maybe they stay home. They say, well, they didn't mean me. They meant y'all.
Mm-hmm.
And
it's always wrong.
I think that's what we struggle with here in the United States, this idea of being free and having a democracy, and we should have the opportunity to go out if we want to go out. So I guess one of the things that I've heard then in what you're saying is anybody who has gotten this disease and ultimately died got it from someone who probably did not show any symptoms. So if you have no symptoms at this moment, but you begin to exhibit them, what should be the first thing you do?
It's, the first thing you should do is you should call your doctor. And if you don't have a doctor, call a health center. They have all the major health centers in all the major cities around are prepared to deal with these calls. They have a script that they ask you certain key questions. And based on your answer to those questions, they direct you to monitor yourself, formally quarantine yourself versus coming in. But if you are worried at all, deal with that by making a call. And also, I want to say to people, this is hard. And that crazy feeling you have in the back of your head where you feel angry or sad or emotionally labile or just something's not right or all that thing, that's grief. We're grieving the people that died. We're grieving the loss of freedom and autonomy. We're grieving the change of our lives. We're grieving a process that is taken from us. And I say that because that mental impact is going to last way beyond what this virus does in real time. Think about all of us in my age group that had grandparents that grew up in a depression. My grandmother used to go to restaurants, and when they gave the free peanuts at the beginning, she would scoop all of them into her purse. And I would be like, why is this woman scooping the peanuts into her purse when we could buy this restaurant twice over? Everything in here on this menu we can afford. That is left over from the trauma of growing up in the depression. I think similarly, when we get to be old people, there's going to be some of our grandkids look at us and say, oh, mama's going to wipe down the whole grocery bag and cart with Clorox wipes. Because that's sort of the residual trauma of what we're going through playing out for the rest of our lives. I put a plug in there to say, be good to yourself. Be kind to yourself. Be gracious with yourself. Be patient with yourself. And extend that kindness, grace, and patience to those around you that you're sheltering with.
All right. I think that is the perfect note to end this on. And I'm typing that in the comments as well.
And if your body is your temple, then treat your temple well. So like you said, do the basic things that move, drink a lot of water, and just take generally good health. Yeah, now I got my water too, albeit it is Pellegrino because I like Pellegrino.
Hoity-toity.
Well, you got to drink what you like, right?
Well, you say, y'all Jaguars are bougie, so that's
yes, indeed.
But treat your body well.
Wow. Well,
Lena Morris, your grandmother too. I know exactly.
Listen, I mean, we had an aunt who, boy, with money, she was tied with that money because of having gone through our great aunt, I should say, having gone through the Great Depression. But one thing I do know is that we are resilient people. Especially those of us. So speaking to those of us who are part of the African diaspora and African American people specifically, the fact that we are here in this country means that we are resilient. We are survivors because our DNA made it through the Middle Passage.
Nah. And what's been amazing to me is watching all these people negotiate these sort of social distancing and societal rules. You do realize that Black people through Jim Crow and the segregated South had to do all this stuff. And if they didn't do all this stuff, the punishment was death.
Amen.
So I think it's always useful to put into context. Like, this ain't the first time we had to stay indoors and be socially distant and avoid stuff we wanted to do.
Hey, hallelujah. And for those of us who are Generation X, this ain't the first time we had to go in the house and turn on that TV and don't answer that door for nobody and don't let nobody up in this house. And it better be clean when I get home.
Yes, 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 yes.
Holly, if you hear me, what about Generation X out there? We all have been there, but we are resilient people. This too shall pass, and we will get through this. So if you enjoyed this topic tonight, please share this video. For those who you have your friends and family members who's been having lots of questions, or they've been spreading some of these myths out there, share this video. Have them reach out to Dr. Mo on social media so we can dispel this stuff. We need to have all the right information so that we can battle this accordingly and know that we will get through it if we work together and do this together. So thank you for tuning in tonight. Like, follow, and share HeyyySister. And we look forward to seeing you on the other side. Dr. Mo and Christine, I'm going to ask that you hold the line while we sign off to the people. Good night, everybody.
Good night, y'all.